I'm going to talk fairly briefly about a piece of work that we've done here in collaboration with the people in intensive care about trying to improve communication and palliative care for people who are facing uncertainty in the intensive care unit. I have to start with a standard acknowledgement and disclaimer. The intensive care unit is a very dynamic, busy, high-tech environment, but actually where many patients die. And it's quite challenging to provide high-quality end-of-life care, particularly when there is this level of prognostic uncertainty, a situation which is also true, I would say, in dementia care. And there's a fair body of research, although most of it in the US, but enough in the UK to be concerned about it, to want to do something, with concerns about symptom control, decision-making, communication, psychosocial support. You do have an advantage in the intensive care unit because it's so high-tech and busy. You do have quite often one-to-one nursing care, but the challenge is that they're very busy doing the recordings of the technologies and not necessarily other aspects of care. So our goal in this study was to try and develop or adapt and evaluate a tool that might improve palliative care and the needs that we could assess in the intensive care unit. And this was a collaborative project between ourselves and the intensive care unit, and in particular my colleagues here who are intensivists sat around the table with colleagues from the palliative care unit. Now, our local intensive care unit has almost 2,000 admissions a year. It serves a local population, but it also supports a regional trauma, neuroscience, transplant and cardiac services for the whole of the southeast of England. And in the hospital itself here, there are 1,200 deaths annually, but actually 20 to 25% of those deaths actually happen in the intensive care unit, making it a very appropriate place for us to start thinking about. And in general, although the data varies, because you have such a critically ill group of people going into an intensive care unit, actually around 30% of people who go into an intensive care unit actually die because they're so critically ill. So the work that we did was, first of all, exploring the concerns that people had and developing something which we eventually called PACE, and I'll explain what that is in a minute. It's in the title though. And we did that by doing a literature review, by doing qualitative interviews, by doing focus groups with both staff, family members, and a small number of patients. And then we developed the tool, revised, piloted it, implemented it, and then surveyed staff and family members about the tool to see how well it worked. So just to start with the views of family members and patients, in a way they highlighted 4 areas of concerns, and this was partly just to check out that our intensive care unit was similar to that we found in the literature. And the 4 areas that came out related to decision making, supporting the patient and family needs, controlling the symptoms, and quite importantly, communication. And you can see the sorts of issues that came out with some of the illustrative quotes here that you can see that came out from the different family members and patients and so on. One of the themes that came up repeatedly was the idea of living with uncertainty, and that things could change and that you needed to be prepared for that. And I see that as something that's actually quite similar with the situation in the nursing home, is the level of uncertainty. Perhaps not quite so intensively acute in the matter of hours or days, but nevertheless quite intensively acute because you're quite uncertain as to what will happen and the outcome. So as a result of that, we decided to develop the PACE for all patients that were admitted to the intensive care unit, not focusing or trying to identify those who were going to die. And this was primarily because it was something that the intensivists said they thought would be helpful. But we had to develop something that would be useful whether patients got better and recovered or whether they got worse. So we had to move our assessment a little bit away from end of life, because not everybody would die, and that would have been unpalatable to say that. And we noted that quite often people didn't even know about the family or the social and cultural needs or what the patient preferences were or what they were aware of in terms of the communication or the information. And it would be quite useful to have an update. And what the staff wanted also is, where can I go for help? Where can I get extra help? So we developed this tool called the PACE. But this is sort of an example of one section of the questions. There were only a small section of the questions, and one of our goals was to have less paperwork, not more. So we managed to get most of it onto one side of A4, so we'd have less, with mainly questions around prompts rather than things that you fill in detail. So if you have any of these things, for example, children under 18, guardianship issues, vulnerable adults, then you should talk to somebody. Has the person any previous wishes? What are they? Who are the people who are most important? Have they heard about just visiting hours, who the staff are? This is a very simple component of it. We did a lot of work on the PACE implementation, and I think we're similar to the earlier presentation about seeing the importance of the implementation and support within this. So we actually did a series of pilots. We did a formal launch with some posters and discussions between ITU and ourselves. We reached consensus about the content. So there was a lot of joint working in that. It wasn't hugely time intensive, but there was joint working to try and in a way make sure that staff were supported in the PACE, and almost the joint working was as important as what was in the tool itself, I believe. The joint working and the joint activity was as important as what else was going on. In terms of the results of the PACE evaluation, and I'm going over this quite quickly because of the time, but basically we had responses from 95 staff who went through the intensive care unit. Nurses were the main people who had completed a PACE, although both doctors and nurses gave us comments on it. Mostly it was completed within 24 hours. When it wasn't, it was usually done within 48. And most people said it was very or generally useful, and the most useful sections were the family details, the social details, and the kind of communication information handover that there was. We also surveyed family members, and we were lucky that we had a group of family members and a part of the ward where the PACE had been implemented, and a third of the family members hadn't, where the patients hadn't had the PACE, and we were able to separate those. So we were able to do a kind of quasi comparison between people who hadn't or hadn't, but this wasn't randomised. But interestingly, the instances where PACE was used, the families were more satisfied with symptom assessment and treatment, and that took me a long time to think about. And I'm still not quite sure of the mechanism, but I'll show you some quotes from the qualitative that might help you think about that. Because the PACE wasn't directly addressing symptom management. They were also more satisfied with honesty and consistency of information about the patient. And I think it's something to do with the tenor of care that relates to the symptoms. So here's a sort of quote. You have an interesting instance here where the member of staff feels quite able to call the nurse over, and then they automatically do something. So there's something in the relationship between the nurse and the family member which is actually impacting on the symptom control, because the nurse feels able to, the family member feels able to immediately call the nurse because there's a problem and the nurse comes over. So there's this different relationship in a way that they're describing. And then here, again, something about the communication, why have you done this, and so on, and feeling that they're having different things. There's a quote here about how the ward's been, or the staff have been meeting individual wishes. So somebody says he doesn't want any tubes down him, he's made it clear, even if he gets worse, and they can put in a tube to help his breathing, he doesn't want it, it's his wish. And I said, well, that's his reply, then let's stick to that, that's what he wants. So a sort of tenor around, okay, we're discussing what the person wants, and this is what he wants, we're going to stick to this. you know, an explanation in the second one about dignity and respects. They're moving him because of the sores, and we've put this onto the straighten the leg, and oh my God, I wouldn't have thought about that myself. So isn't it good that they've suggested that? We developed a sort of theoretical model to try and understand how PACE might be acting to improve care. And I think this is quite interesting. It builds on other theories about how you influence changes in practice. But what's in the yellow, in a sense, is the components of what goes on in the PACE, which is about the recording and the information, but also, importantly, the training. And asking information and collecting information about preferences on a regular basis actually reinforces the attitude change that you might want to see. And then to underpin and help staff, because often these things are quite overwhelming. If you do discover something that's difficult to manage, then you have your numbers to contact. So you're not frightened to ask about things, because you know that if I pick up these problems, I'm not left on my own having to deal with them. There are then these numbers that I help with. And our theory is that this then leads to families feeling that there's a greater sense of continuity in information because there's a record. People are being asked about what's important and what matters to them, and that reinforces the positive feedback in the change in attitude of staff. Staff are also will become aware of the preferences of families, and there's a more timely referral for additional support for staff. And then these lead to the potential outcomes that you might see. So in a way, what we've tried to do in this model is build how it might be working to the effects that we see. So in conclusion, this was a collaborative study that was designed specifically to support staff to develop a complicated intervention to meet these very high and complex needs in an inner city intensive care unit. And it seems that the psychosocial assessment and communication evaluation as a tool was acceptable and feasible in this setting, and it allowed an earlier assessment of patient and family circumstances beyond the medical diagnosis. Our view is, and what we're going on forward now to look at, is to whether it's actually going to be helpful in other situations of high uncertainty and complexity, including in sort of nursing homes or with elderly people, potentially in dementia care, as an adjunct to other systems that are in place. So thank you very much for your attention.